There are currently three steroid agents available for intravitreal delivery for diabetic macular edema. These are triamcinolone, fluocinolone and dexamethasone. Now we'll start with triamcinolone, and essentially the earliest trials of intravitreal steroid for diabetic macular edema used Kenalog, which is a form of preserved triamcinolone. There were some rare case reports of sterile endophthalmitis, which we suspect related to the preservative in Kenalog. Therefore, later triamcinolone preparations were made to be preservative-free, for example, Trivaris or Triessence. In terms of clinical trials, 5-year data from the TDMO study showed that there was a 9% rate of incisional glaucoma surgery with triamcinolone use at 5 years. Moving on to fluocinolone. Originally, it was used at quite a high dose in the RetiCert implant. There were rates of incisional glaucoma surgery reported over 30%, and therefore it was not licensed for use in diabetic macular edema. Later, lower concentrations of fluocinolone have been developed into a slow-release implant of fluocinolone called ILUVIEN. However, in the clinical trials, there still was a 4.8% risk of incisional glaucoma surgery required by the end of the trial at 3 years. In terms of dexamethasone, the Osidex implant has been shown to be of benefit in trials like MEAD and Bevidex, with low rates of incisional glaucoma surgery, less than 1% in these clinical trials. At this stage, the largest body of evidence is therefore the intravitreal dexamethasone implant, or Osidex. There's clinical trial data from a number of different trials, including MEAD and Bevidex. What we've seen, though, is that we want to replicate clinical trial outcomes in real-world populations. In real-world populations are more representative of the patients that we see, who might be excluded from seminal clinical trials, for example, because of having comorbidities. There's a study called the RELDEX study, which showed encouraging real-world outcomes with the use of intravitreal dexamethasone for diabetic macular edema. And it was interesting that the visual outcomes in the RELDEX real-world study were very similar to the clinical trial outcomes in terms of visual acuity and side effect profile. It's worth bearing in mind that clinical trials and real-world evidence have their relative merits. Clinical trials have high internal validity because of their controlled and randomized natures. However, the results apply to the selected populations included in these studies. Real-world studies allow us to look at how these clinical trial outcomes actually can be generalized to the real-world populations with real-world constraints. What's interesting is that if we look at real-world studies of intravitreal steroid for diabetic macular edema, for example, the IRIS registry or RELDEX study, the visual outcomes were very similar to those achieved in seminal phase 3 clinical trials. When we look at anti-VEGF therapy, the LUMINOUS real-world study did not achieve the same level of visual gains as seen in the seminal phase 3 registration trials. And it can be speculated that the reason for that would have been the high number of injections required in year 1, which can be achieved in a clinical trial setting, but is more difficult to achieve in a real-world setting.